talked about how the body normally will repair a torn blood vessel. Okay, that's what we've already talked about. But there are people that are not going to be able to repair that blood vessel successfully. And there's tests that can be done to see what is going on with that normal mechanism of repairing a blood vessel in that individual that can't repair a blood vessel. And the reason why they might be evaluated for this is there's family history of bleeding. Or there's themselves, they continuously have manifestations of bleeding. So they want to figure out, well, why? So that might be one reason that they get tested, okay? It's just a history, either family or personal. The other one is, let's say they come into the ER and they're bleeding, and every intervention that they try to give to stop that bleeding isn't working. They keep bleeding. So they're going to want to do an evaluation and see if certain things might be contributing to them not being able to stop that bleeding as a healthcare facility, all right? And then the last one is they'll evaluate people that are actually taking anticoagulants for various other reasons. Like my husband, when he was in the hospital for 3 weeks because he got an infection when they did back surgery on him, they were potentially considering giving him anticoagulants because he couldn't move. He was just laying there, and they kept giving him more and more drugs that could have caused clotting and coagulating in his blood vessels. And so to thin that blood, they gave him anticoagulants. But you don't want to make it to where if something did happen, they start bleeding out and go into shock. And so that's another reason why they might evaluate these different factors that could lead to bleeding, excessive bleeding, all right? The things that they're going to evaluate is, of course, they're going to do a blood count or platelet count. But they'll do a complete blood count. That's called a CBC. So these are the tests that they'll do to evaluate what might be going on if you're bleeding excessively and it can't be stopped, or if you're under treatment for thinning. So complete blood count. That's one thing that they're going to look at. Another thing that they look at is they look at the time it takes for you in your bleeding, okay, and to stop that bleeding. And so one is just an overall bleeding time. We'll evaluate your bleeding time, how long you are actually bleeding out before it stops. And I don't even know exactly how they test these, to tell you the truth. I don't know if they do it in a tube or what, you know?
They have little machines.
Oh, they do?
Yeah, you can prick somebody's finger and then
Oh,
machine.
really?
Mm-hmm.
Ah,
It's
machines.
almost like a glucometer.
It's like the machines do it for us, right?
But yeah, it measures the,
The
from
flow of
food
blood.
and therapy. Yeah, it measures what their trough is and their system.
Oh, cool.
Measures, yeah.
Thanks. This is just overall the first one, it's
Okay.
bleeding time.
Mm-hmm.
And then the, and this is really, the bleeding one is seeing for, vascular function and platelets. So it's really testing like, oh, hey, are these platelets working? Think of the bleeding time as that beginning part. Hey, can that blood vessel do a vascular spasm? Are we getting a platelet plug? All right? So that's what the bleeding time is really testing in this evaluation. And then they will do this thing that's called PT, and PT is prothrombin.
So that's what I was talking about.
Time. And then there's this other thing that's called APTT. And this is activated, that prothromboblastin. I'm going to make sure I write it right. partial, they're calling it partial here, partial plastin. So thromboplastin, we saw that, or a factor in that intrinsic pathway. So when they do the APTT, they're actually testing if the intrinsic pathway is functioning properly when they do that, okay? So this is to test the intrinsic. And this, they're testing the extrinsic. See if that one's working properly. And so those are the types of things that they're going to do to evaluate and figure out, well, hey, are you bleeding because you have some type of blood vessel dysfunction? Or something's wrong with your platelets, all right? Here they're going to be testing in regards to those coagulating factors. Do you have the coagulating factors that's needed to do this extrinsic pathway? Do you have the coagulating factors to do the intrinsic ones? These are going to figure out with that, all right? And kind of pinpoint what's going on in that person and what's causing them to not be able to stop that blood loss, all right? There's various blood cell disorders. I have a table where I put them all together. There's a lot of them. Some are specific in regards to, hey, there's something wrong with the blood vessel wall. All right, it can't do its job, and it can't vascular spasm, or it's weakened, and so that's going to cause bleeding to occur more regularly. Something might be wrong with someone's platelets. They aren't making functional platelets or enough platelets to start that plug, or it could be a consequence of not making functioning coagulating factors, all right? And so when you read through the pathogenesis, that should trigger you, or the etiology, that should trigger you into which one these different ones are from. Is it vascular? Is it from platelets dysfunctioning? Or is it from something wrong with the coagulating factors? All right? Hey, vitamin K deficiency. What is it? What's wrong there? If someone is bleeding because they are not absorbing vitamin K, which one of those three things is awry? Is it the blood vessel itself? Is it platelets? Is it coagulating factors?
Coagulating factors.
Coagulating factors. So many of them are dependent on vitamin K to be made. All right? Liver dysfunction. Now this is going to be secondary, right? I mean, you get so many other things wrong in your body if your liver is not functioning properly. But most all of your coagulating factors are made in the liver. If it's not functioning properly, you're going to probably secondarily have bleeding occur. So stuff like that. So when you're going through these, really think of the big picture here and initially start to think of, well, why is this? Instead of trying to jam in your brain all these little details and not understand why, okay? It's going to make it so much easier if you try to look at the big picture and understand why, rather than getting all these itty-bitty details, okay? And I'll come up with some practice questions for you to utilize this table for, or with. Oh, that's yours. Oh, yeah, do you both need an extra in your one? Okay, then do that. Yeah. else have the anemia one? All right. We are done. Now we're going into brain disorders. All right. Okay. I don't know why I put handle here. Hand. So this is, I believe, chapter 44. So these are acute brain disorders. And acute brain disorders they're called acute because they're going to be fast, sudden. So it's just going to suddenly happen, this type of disorder. Just
Stroke.
a stroke is an example. Trauma, like hitting your head. All right, these are causes to having this sudden brain disorder or loss of function. Really, when we're talking about acute brain disorders, you're going to have initially loss of function. So you're going to have loss of function from that initial injury, such as a stroke. So stroke is where you're going to actually block blood getting to brain tissue. And then that brain tissue that's not getting that blood is going to have damage because it's not getting the glucose it needs, the oxygen it needs. So the primary assault with acute brain disorders is where you are going to ultimately lose function of some type. Now the thing is can you prevent further damage? The thing is once this starts happening, the further damage happens very fast, okay? So loss of function initially, and then further damage is going to be fast, occurs quickly. And that's why they're called acute, actually. It's sudden, and then the progression of it is very fast when this happens. The things that are main causes here is, trauma. Some kind of mechanical trauma, like getting hit in the head. The other one is it could be cardiovascular disease. So stroke would fit into this, the cardiovascular disease. You could also have associated with a stroke, you could actually, because what you're doing with a stroke is you're blocking blood getting to that brain tissue, all right? So you could have a embolism. You could have also rupturing of a blood vessel. And when you have rupturing of a blood vessel, that's a hemorrhage. So hemorrhaging could also be a primary cause to this acute brain disorder. And then infections. That's the one we're going to talk about at the end is infections. Okay? And some infections can cause this sudden, fast progression of loss of function in the brain. All right?
So in which category would ischemic stroke fall under?
Cerebral vascular disease or trauma. And we're going to talk about how...
So with the cardiovascular, it would be like an embolism that travels from somewhere from the cardiovascular system to the brain?
Yeah.
Okay.
You could also have situations where autoregulation is messed up. And so when that starts happening, you can start to see edema occur. And when edema occurs, it then compresses on those blood vessels, causing ischemia. And we're gonna see there's this cyclic thing that starts to happen, where you get edema, leads to ischemia, leads to vasodilation, leads to more edema, and just keeps going in this cyclic fashion. Now, the thing about acute brain disorders is, yes, they are very complex, and they do have a lot of parts. And so we're gonna be kind of looking at the mechanism here in regards to thinking about essentially how ischemia and hypoxia are really leading to this edema. Because when we talk about acute brain disorders, that's really the big component here, is having ischemia and hypoxia. And in this particular section, I want you to think about ischemia and hypoxia as being the same thing. They're very closely related here, all right? You're gonna wanna get a certain amount of blood to that brain tissue, all right? And within that blood, you're gonna want to have high oxygen levels. And the reason why is because of neuronal cells, all right? Neurons are highly metabolic, all right? They are making lots of neurotransmitters, lots of proteins that are going to be these voltage-gated channels to allow for electric current signals to go across their axons and allow for one neuron to talk to another. So they're going to be very highly metabolic. But they do not have any oxygen storage or any glycogen storage. So these neurons that make up your brain tissue are highly dependent upon the blood that's being delivered to your brain, okay? And when you block off that supply of blood, these things start to die, these neurons, okay? And so blocking off blood, like in ischemia, is going to be a part of hypoxia. They're very connected in this particular situation. Everybody good with that? So, when we're talking about the initial damage here, is going to have loss of function. You're going to have secondary damage. And really what the secondary damage is about is in regards to how severe is the reduction of ATP. Okay? Really, how severe is the reduction of these neurons not getting blood to them to make ATP, all right? And if we're talking about moderate reduction in making ATP, I want you to think we're talking about neurons here, versus severe reduction. Okay? These cells are going to die. That's what this is ending up. This further damage, you're going to already kill cells initially with that primary assault on the brain, all right? And now you're not getting blood. Therefore, oxygen and glucose aren't going to these neurons. You're going to see very quickly a rapid progression here of the other neurons starting to die. Now, when we talk about cell death, there's two ways we can describe it. One that has inflammation and one that doesn't. Which one has the inflammation? Necrosis. The other one that doesn't have the inflammation is what? Apoptosis. So which one do you think is gonna go underneath the severe reduction of making ATP, necrosis or apoptosis? Necrosis. So these guys are gonna start to lyse. And then everything that's in that neuron is gonna get released into the area. You're gonna get a bunch of inflammation. And as we all know, inflammation leads to even further damage, okay? Where if you have a moderate reduction in making ATP, you're just gonna have these neurons do apoptosis. Neither one is really appealing because neurons they replace themselves. No. Okay? So neither one of these is awesome, but the thing that can happen is if you do get to a point where you can stop this secondary damage and not have further damage occur, those neurons, even though there's a significant amount that have died, they can make new pathways and talk to other neurons. So then the new pathways they make aren't going to be as fast, the processing will be lower, but some people can relearn things depending upon where the damage has occurred in the brain, all right? Now, before I go into this, I'm going to put over there this big, huge chart that we're going to bounce off of, all right, in regards to what's going on. And the big thing that's going on with acute brain disorders is ischemia. That is the big, major contributing factor here. I can find my table. Oh, my table's right here. Okay, ischemia is going to be the big one. You're not getting blood to those highly metabolic neurons. They can't make ATP, all right? And they're going to start to die. Now, with ischemia comes hypoxia, all right? But ischemia, we're going to see, is also going to lead to an increase of this oh, shoot, it's going wrong. Oh, no. I'm going to talk about glutamate here in a little while because we're going to see that with this increase in glutamate, this is going to have a big chain of reactions that starts to cause even more damage with these acute brain disorders, all right? If you're not getting oxygen to these neurons, what organelle is not going to start to function anymore?
Mitochondria?
Right. So we're going to get mitochondrial failure. Happen. Now, with a mitochondrial failure, we're going to see that we get a decrease in ATP, right? That makes sense. Mitochondria aren't working, we aren't making as much ATP. The other thing that mitochondria does is it sequesters calcium. But now they're failing, so they're no longer going to be sequestering calcium, these mitochondria. So a decrease in mitochondria sequestering calcium, right? With a decrease in ATP, our pumps aren't going to work, all right? And in this situation, I'm going to just keep focusing on calcium here. So we have calcium pumps. So we're going to have calcium pumps stop working. We're going to also see, and we're going to go into the exact mechanism of this, but ultimately with this increase in this neurotransmitter, this is a neurotransmitter, this neurotransmitter eventually is going to activate these channels that are called NMDA channels. And with the NMDA, and it just has that name because of the components that make up this channel. And we're just going to go with the acronym now because I looked up that word and it was too much chemistry. Sorry. I'm like, that doesn't make any sense to me. It's a bunch of chemistry stuff. It's easier for this particular situation. Just NMDA. It's going to activate them. When it activates them, calcium rushes into this neuron. All right? So all of these things here, mitochondria are not, they're not hanging on to the calcium now. Pumps are not working. You get an accumulation of calcium in the cell as well. Oh, look, now more calcium is going into this cell because of this glutamate eventually making these channels allow calcium entry. This is going to lead to calcium overload in that neuron. All right. Now, ultimately, what calcium overload is going to do is, we've seen calcium before. Calcium was in those coagulating pathways. It was a factor that activated proteins. That's what calcium does. It has this charge. It binds to an active protein and makes it active. And so when you start to get more calcium inside this cell, you're going to activate a bunch of proteins in that cell. So you're going to increase metabolic activity. When you increase metabolic activity, what's a byproduct that could damage this cell?
Free radicals.
Free radicals. I don't know, what did you say?
I said CO2, but that's a little different.
Yeah, CO2 is a byproduct of cellular respiration. Right.
Free radical.
Free radical. Remember the free radical theory of aging? Smaller animals have a higher metabolism. They do more metabolic processes. They dump off more free radicals. Free radicals bind with protein structures of a cell, making them non-functional, and they start to degrade and age. That's that free radical theory. You guys remember that? So this is a similar thing that's going on. This calcium overload is increasing the metabolism of already highly metabolic cell. You're going to increase free radicals here because of that. All right. Now, you could also, whenever this is happening, the body wants to bring blood to those neurons. And so it's going to try to do that. And when it does that, it's going to, when we're trying to restore blood supply to tissue that has been blocked from that blood supply, what is that called?
Reperfusion.
Reperfusion. So we could have reperfusion start to occur here as well. And when we have reperfusion occur, we got to realize that this is happening, we're already having injured cells. And so this is going to bring with it leukocytes and inflammation, all these things we don't want. But it's also going to bring, oxygen, right? But oxygen actually is highly reactive into increasing these free radicals. So it has this effect as well when you do reperfusion. So you're going to, with reperfusion, bring in oxygen. You're going to bring in immune cells as well. And all this stuff is going to lead to what for these poor neurons? Death. Okay? And this is where it gets complicated. There's all this stuff going. All right? So it is a really complicated process, and they don't even entirely understand. But this is a great little outline to bounce off of for what's going on, big picture-wise. Cell death. And death. questions about that table? No.
Will that calcium affect how neurons fire? Because isn't calcium what's released in that acetylcholine at the neuromuscular junction?
Yeah, but we're really talking about interneurons here, and yeah, calcium is going to facilitate the release of neurotransmitters
So
at
would
this
those neurons have
axon
a
terminal.
lack of calcium or too much calcium?
This is calcium overload,
Okay.
because what's
So they'd be
happening,
firing ideally more than normal?
right, we're gonna see that ultimately what ischemia does with this, we're gonna look at this glutamate neurotransmitter, and what's happening here. Because with the lack of ATP, because it's much more complicated than this picture sets out for it to be. But with the lack of ATP, you're gonna find that a lot of the proteins aren't functioning properly to begin with. And this glutamate is gonna get released when it shouldn't be released. And because you don't have ATP, it's not being taken into that neuron again, so you get a whole bunch of it at that synapse. And I wanna mention that this is an excitatory neurotransmitter. And a part of this, I mean, the way I think of it as the big huge picture and everything, really what ends up happening is these free radicals start to damage the cell. That's the big ultimate end to all of this, actually. All right? And this calcium just building up into this cell is gonna have a couple of consequences. It's gonna turn on enzymes that shouldn't be turned on, increase your free radicals. But if we get more calcium inside the cell, what actually also happens?
Doesn't this also happen in a heart attack? Same thing, calcium overload?
Probably because ischemia is involved again, right? And what is the first thing that happens in cellular injury when we're talking about ischemia?
Na rushes in, sodium rushes in.
Sodium
water
rushes
follows.
in, water follows, hydropic swelling, it lyses. Here, yeah, we're talking about calcium, but it's the same thing. This is hypertonic now. Is water gonna come into this cell?
Yes.
No. Not because of this, but you're talking about, that's what I meant, is like, isn't this the same thing that happens in a heart attack when the heart muscle dies basically, and it has, you have.
That's
that
what I'm
calcium,
saying,
right?
like cellular injury, you're messing up the ionic concentration, making more ions inside the cell, which causes water to rush in, which is gonna happen here. It's not sodium, it's calcium instead, but it's the same thing. You're gonna have more solutes, less water, water's gonna rush in, and you're gonna have hydropic swelling. And what they call it in this particular chapter is cytotoxic edema. It's hydropic swelling.
The edema or edema?
Edema,
Okay.
okay, E-D-E-M-A, edema. All right? But yeah, I imagine it's a very similar mechanism, because what's happening there is you're not getting blood to cardiac muscle, which is also highly metabolic. All right? Yeah. The exact specifics of that particular mechanism, I don't know. But the general big picture is very similar. Okay. Other questions? All right, so I want to focus on what's going on with that glutamate, all right? We're going to see, I can erase this too. I can erase all this, right? Okay. another, but this is the axon terminal. And then this is the dendrites and cell body of the other neuron. All right? So this is a synapse. This is where one neuron is talking to another neuron, all right? When you get ischemia, you're gonna make it to where this neuron is gonna start to release at its axon terminal a bunch of glutamate, all right? So G is this glutamate. That triggers this excitatory neurotransmitter to be released from neurons at their axon terminals, at these synapses. So this is a part of the mechanism, and it's part of why these acute brain disorders are going to progress very quickly. They happen suddenly, yes, and that's because neurons are highly metabolic and need that glucose and oxygen, right? But then this is going to happen. This is one particular hypothesis as to why it goes very quickly and rapidly, all right? And starts to turn into that apoptosis and necrosis of further neuronal cells, all right? Now, these cells aren't going to be able to make sufficiently the right amount of ATP. So this glutamate is going to hang out in this synapse. Normally, you would have reuptake receptors that would bind to this glutamate and bring it back in to the neuron. But you need ATP for them to function properly. And these cells aren't making ATP, all right? So this glutamate, it's going to bind to a receptor of this postsynaptic neuron, all right? And this receptor, when it binds to it, is called AMPA. The name isn't that important here. The simple fact is that this glutamate is binding to this receptor. That's called AMPA. This receptor, when glutamate binds to it, is going to open and allow for sodium to rush into this neuron. Okay? So when glutamate binds to this receptor, it opens. All right? Sodium rushes in. Are we good with that so far? Yeah? Okay. Now, is inside of this neuron, is it more negative or more positive normally at rest? More negative, right? So think of this being more negative here, right? But sodium's rushing in. So what is that going to do to the membrane potential here? It's going to make it more positive, right? So as sodium rushes in, what are we doing to the membrane potential? Are we depolarizing, hyperpolarizing, repolarizing? What are we doing?
Depolarizing.
Depolarizing. Because remember, glutamate is excited. We're going to depolarize. Okay? So we're going to depolarize the cell membrane here. And you're going to have another molecule over here. Another receptor. This receptor is called NMDA. Glutamate's going to bind to it. But this positive depolarization that's going as sodium's rushing in, here from the very beginning of this, it changes the shape of this molecule. All right? Think of these things that have positive and negative charges. When they bind to something, what they're really doing is changing the shape of that molecule slightly, okay? Activating it, making it have the right shape for it to do its function, all right? So glutamate and depolarization activate NMDA channels. Okay? Now this guy is a channel. It'll open now. Who do you think is coming in? Calcium. That is right. Look at our chart there. It's going to activate NMDA channels. That leads to calcium overload. We filled in some blanks here, though. All right, we're looking at it a little bit more detailed to see what's going on. Everybody okay with that? So now calcium's going to rush in. Calcium rushes in. And we get back to what we were talking about over there. We get a calcium overload. Enzymes get activated. We get an increase in free radicals. Those free radicals are going to start to bind and make proteins of this neuron not functional. All right? And ultimately, the other thing that's going to happen here is we increase both sodium and calcium. What's going to move in? Huh? Water. So then you're going to get water coming in. Water rushes in. And what we call it in this case is cytotoxic edema. All right? We're now getting to the point of this neuronal cell is approaching death. Okay? Are we okay with that? Now, this is going to be this is one mechanism that's going to lead to these neurons dying, an acute cerebral brain injury. All right, that's what we got to keep in mind. We're talking about acute cerebral brain injury. And the big thing that's going on is these neurons aren't getting blood and oxygen. These various things are going to start to happen because of that. Now, the other thing that we can think about is, well, let's first just talk about autoregulation. What is autoregulation? Does anybody remember what that term means? Yes, it has to deal with blood pressure, and it has to deal with delivering enough blood to the body's tissues, okay? So autoregulation is where at a specific location in the body, the amount of blood that's going into capillary beds is regulated by arterioles that are feeding blood into those capillary beds, all right? And so autoregulation is about delivering the appropriate amount of blood to the body's tissues. Okay? I mean, a part of this also is making it to where you're not having those capillary beds, the pressure increase so much that they burst as well, right? Good? Now, let's set up like a normal scenario here in autoregulation. This is what's happening. Let's say your neurons increase metabolism. Okay? So they're really metabolically active, your neurons right now. Is that going to cause the arteriole that's feeding blood into that capillary bed to do vasodilation or vasoconstriction? Dilation, right? Because you want to get more blood into that capillary bed. So this is going to lead to vasodilation. All right? Now, this makes sense, right? If we're talking about other things that are going to be lumped together with this, we want to think about MAP. Are we going to have vasodilation when there's a low MAP or a high MAP? A low MAP, right? Because you ought to remember that this is also protecting those capillaries from bursting, right? And if you have a low MAP, that means that the blood, it's not perfusing well enough to those tissues potentially. So you want these arterioles to be vasodilated. Everybody good with that? So you're going to have a low MAP here. The other thing that's going to be involved with this is an increase in carbon dioxide. Think of this one here, this increase in carbon dioxide. If these are highly metabolic, they're dumping off a lot of carbon dioxide. Okay? They're making a bunch of ATP, and carbon dioxide is a byproduct of that.
I just want to clarify on the map that you're talking about mean arterial pressure, right?
Yes, mean arterial pressure. Everybody's okay with that? Yeah? Now, normally, if we have a low carbon dioxide, what's going to happen? That means these aren't highly metabolic, right? They aren't making as much ATP, you're not getting that byproduct of carbon dioxide. Are we going to have vasodilation here? We're going to have vasoconstriction, right? The other thing to think about with this is in hyperventilating. Now when you're stressed out, you don't even know it sometimes, that you're hyperventilating. This is dealing with test anxiety. You start to hyperventilate, you don't even know it. You actually are going to end up having a decrease in your concentration of carbon dioxide. That's going to cause vasoconstriction. You're going to then decrease the amount of blood that's going to your brain, and you're not going to think very well. So, and sometimes you don't even know you're doing this, but that's a part of test anxiety. That's where if you kind of are looking at something and you just doesn't make sense, you're like, what is going on? Step back, start taking slow, deep breaths. That's going to increase your oxygen levels. That's going to allow for vasodilation to occur at the brain. Right? This is normal. Right? Now let's talk about abnormal. So, vasodilation. So your blood vessels are unable to properly or sufficiently vasodilate. All right? Now, there's several things that could be the cause of this. One of the things is you got a thrombus going on. You got blockage. And even though this thing is vasodilating, doesn't matter. You're still not getting enough oxygen and blood to that brain tissue. All right? Still good? Thrombus and embolism could be in this. This is really where we're talking about stroke going on. All right? Sometimes your blood vessel might be doing vasospasm because there is an injury, so it's not able to vasodilate to get blood to that tissue. So a vasospasm could be in there as well. That's making it not properly vasodilate. You can also have, where this blood vessel is, you can have tissue edema that's compressing on it. So even though it's trying to open up, It can't because the tissue around it has built up fluid that's collapsing it. All right? Is everybody good with that? Surrounding blood vessel. I'm just gonna, BV means blood vessel. What's gonna happen in this situation? This guy can't vasodilate. What does that lead to? Ischemia. Again, all right? So this is gonna lead to ischemia. Now let's talk about what's going on. So that's if, autoregulation is screwed up. And again, how it could lead to this whole thing over here. This big table that we have going on. Everybody still okay? All right. And this is, in part, hey, this is a stroke. Oh, hey, this is trauma to the head, right? All this kind of stuff can lead to ischemia. We'll go with that.
Like a blunt force.
Right. Now, the other thing that could happen is, hey, you could, you're not unable to properly vasoconstrict. These things are very, very tightly bound together, ischemia with edema. We're going to start to see that these things, like I said, have a cyclic thing going. Because, hey, edema's in this one that causes ischemia, right? Unable to properly vasoconstrict, you know what's going on here? Vascular injury. Bash on the head. It can't vasoconstrict because the blood vessel's torn. You get buildup of fluids in the tissue. You get edema, leads to ischemia. So all these things end up, and this is why it's so complex and convoluted. One thing leads to another, that leads to another, and back again. All right? This is a vascular injury. You guys good with this as a part of this mechanism of acute brain disorders? Any questions with this? Oh, before I move on, I want to add something. So we were talking about MAP here, and when we're talking about getting into this ischemic situation, this is where MAP is going to be 50 millimeters of mercury or lower. All right, we're getting into this, just in general, like having this vasodilation occur with a low MAP. All right, that's going to trigger this vasodilation because your body is trying to get blood to the brain. That's hypotension there. All right. You could also have a situation where you have a MAP that is greater than 150 or greater. This is hypertension. All right? In this situation, this autoregulation is going to want to do vasoconstriction because you don't want capillary beds to burst. Because it's such the high pressure there. It could cause them to burst. What?
It's great, right? It's like what you keep on saying, each problem creates this.
Yeah, vascular
larger
injury.
problem, right?
Exactly. It's all very connected. Now, when we're talking about acute brain injury, the thing that's gonna be the primary cause of further damage is edema, okay? This buildup of fluid in what's called the intracranial space. Or in the skull, okay? Within the skull, all right? And as you're building up fluid in that skull, what is that doing to the pressure?
Increasing.
It's increasing. So the intracranial pressure, also known as ICP, intracranial pressure. Is actually pretty low. It should be pretty low, between 0 to 15 millimeters of mercury. And if we're talking about what's contributing to the volume that gives us this intracranial pressure, there's three things that contributes. Blood is one of them. So the blood that's being delivered to brain tissue. Brain tissue itself. And cerebral spinal fluid. These are the three main contributing factors to this intracranial pressure, because these are the majority of the volume of what's in your skull. Now, when one is compromised, the other tries to compensate for the increase in the other, all right? Because ultimately you want to maintain this pressure, because if you don't, what'll start happening is as you increase this pressure, this volume, you're gonna start to have brain tissue be compressed upon, all right? And then that's going to lead to that brain tissue not able to function properly. If we're talking about blood, if we get an increase in brain tissue or cerebral spinal fluid, how does blood compensate? What will happen to decrease the volume of blood in this skull area? Vasoconstriction. That's how it compensates. So to decrease blood volume, vasoconstriction will occur. But we all know how that works out. That's not a really good, great way of doing it. So typically that's not, I mean, it'll do it, but at some point that's going to cause a problem. Now brain tissue, do you think that, what does it do to compensate? Can it compensate?
To compensate,
If you get an increase in either of these?
It'll just have a lot of
No,
pressure on
it doesn't. Because brain tissue is neurons. And you got a certain amount of neurons and that's it. And they don't make more of themselves, and they take a long time to remake new pathways and stuff. So this one doesn't really compensate. What about cerebral spinal fluid? So cerebral spinal fluid, your body makes it at a certain rate, and it gets rid of it at a certain rate. And where does this cerebral spinal fluid go once it's gone through all those ventricles in the brain?
what do you mean, outside of your spine, or what are you talking? Where does
The
it-
pathway, so it's in these ventricles, right? And then it's gonna be bathing your brain in that subarachnoid space as well. And then, when it's not cerebral spinal fluid, where does it go?
Back in the bloodstream.
Back in the bloodstream. So one way that cerebral spinal fluid, the compensation of if you get an increase in blood or brain tissue, is it's going to shunt more of itself back into the dural sciences. That's one way. gonna shunt it down the spinal cord. Decreasing the volume, all right? So it's just these three things make up the majority of the volume that's responsible for this intracranial pressure, and two of them can compensate for an increase in one of the others. One will do vasoconstriction, the other one is gonna shunt cerebral spinal fluid, those components back into the blood and have it go out or down through that spinal cord. Everybody good with that?
The whole point, it's that it didn't do it at that point. When you say dural sinuses, it just kind of accumulates either that or in the spinal cord, but it can't really perfuse into the blood because of the blood-brain barrier between cerebral spinal fluid. I know it perfuses, but it's very slowly. So isn't this, when you say dural sinuses, is it just kind of like an accumulation in a different outside of the in sinuses, basically?
It's going back into the blood in that situation. And this is only in rare cases where you don't want this pressure to go more than it should. And so these can compensate for an increase in the other. But honestly, when you start to actually have this happen, there's really not gonna be that much room anymore. You're gonna start to have compression. Different brain structures are gonna be pushed to a different place. And sort of like, hernias. You've heard of hernias, right? So like parts of your brain will push into another area where it shouldn't be. Just like your stomach could push into your thoracic body cavity where it shouldn't be. That's a hernia. That kind of stuff will start to happen here because it can't adequately compensate for the increase in one or the other.
Medical intervention.
Huh?
Medical intervention. Take a little bit of your soul out.
I mean, we gotta remember, these things are fast,
Right. No, I'm saying.
They're happening
they're
very
doing-
quickly.
No, I'm
and-
saying this happens in your living room. Forget it.
Yeah, and I can imagine that some of the things that they try to do to lessen this is some type of drainage
So drill a
somehow.
hole into the skull to relieve the pressure.
Yeah, just to relieve the pressure, first of all, because it's limited, this space.
If they can't get to it within 24 hours,
It's
it's
done.
out here pretty much.
Yeah,
Bring out.
and that's the thing about these acute brain disorders. They're very fast, and once they start going, if you can't stop it from happening, that person will die. Now, just to kind of keep in line with this whole thing, you got this pressure going on, right? You got this volume here. Then you have this crazy graph. And this is called the Monroe-Kelly hypothesis. And this is a part of the Monroe-Kelly hypothesis. This is a hypothesis, mind you. This is what they think is going on. So it might not be. It's a hypothesis. It's not even a theory. But you're going to have, and this is milliliters. This is millimeters of mercury. And you're going to have something like 3 milliliters. Right about here. Doesn't matter the amount that you increase in the volume here, the pressure is going to stay the same. So at this point, it has a level of compliance. And all that means is that as you increase the volume within this intracranial, within that skull, the pressure isn't going to go up very much anyways. It's going to stay about 15 millimeters mercury. All right? But then, as you get more and more, and you start to reach it up to like 7 here. So this is where you have a lot of compliance, okay? Here's where you have a low compliance. Meaning every little millimeter extra, the pressure's just gonna keep skyrocketing. all right? And it's not gonna stay at this functional pressure, right? The thing that is going to contribute to an increase in this intracranial pressure is what? What's the big thing that's gonna happen here to increase volume? Anyone?
Concussion, what do you mean?
What's gonna increase the volume here? What's a big thing that causes an increase in volume in this skull? When we're talking about acute brain disorders.
Edema?
Yes, edema. Thank you. Edema. All right, we'll start there on first.